Wednesday's atrocities. I don't think the House is pausing, but I'm sure our thoughts are with them today. Mike Freer to move the motion.
Thank you, Mr. Mayor. Could I associate myself with your comments, which are exactly right? Mr. Mayor, I beg to move that this House has considered the findings of the All-Party Parliamentary Group on HIV and AIDS 2016 report, The HIV Puzzle, Piecing Together HIV Care Since the Health and Social Care Act 2012. Mr. Main, it's a pleasure to serve under your chairmanship today, and I'd like to put on record my appreciation to the Minister and to other colleagues, but especially the Minister, who has been extremely supportive of the group and has always been helpful whenever I've raised issues relating to HIV/AIDS with her. I'm also grateful to other members for spending their time on, we know what is a busy day today, with other demands on our time, so spending time in the debate is much appreciated. Since I was elected as chair of the All-Party Parliamentary Group on HIV/AIDS in 2015, our main objective has been to draw on evidence from clinicians, patients, HIV charities and research groups who are concerned about the potential impact of the Health and Social Care Act on HIV treatment across England. For that reason, in December 2015, we started to collect written evidence to investigate whether these concerns were based on reality. The inquiry took about a year to conclude, and in that time we've heard from clinicians, local authorities, public health officials, people living with HIV and the charity sector, and we took both written and oral evidence. After a year of evidence gathering, I think it's fair to say that fragmentation has occurred, and that has created a degree of uncertainty, and that has presented opportunities for aspects of HIV care to fall through the gaps in commissioning bodies, which I'll outline later in my comments. The report's purpose, Mrs. Main, was not to turn back the clock, but to reach out to the sector for evidence and recommendations that will make tangible improvements in commissioning HIV services. Because we need to work together to make those changes to ensure that people continue to maximise the benefits of what is a world-class treatment and clinical care service available in the UK. And I want to underline that the majority of the report's recommendations focus on the need for clarity and accountability for all aspects of the HIV care pathway. Because it's the lack of clarity within the Act that came into sharp contrast. It was exemplified by the debate surrounding the provision of PrEP and the uncertain future for HIV support services. I, along with my colleagues on the APPG who advocated for central funding for PrEP, welcome NHS England's announcement of a new PrEP trial that will reach 10,000 people. But our report has concluded that the Health and Social Care Act has increased fragmentation on many aspects of the care pathway, from prevention to long-term condition management. Fragmentation has created risks to HIV support services, for example. A separation of sexual health and HIV services is another example, and there are now new potential barriers to testing and prevention, and most importantly, confusion over the commissioning of new prevention techniques. And I'd like to highlight key findings and offer some suggestions as to how the APPG believes the report's recommendations can help address them. HIV support services, i.e. non-clinical services for people living with HIV, have long been considered a vital part of the care pathway for people living with HIV. The NICE-accredited British HIV Association, BIVA, which provides official guidance for HIV treatment and care, states that the following are necessary for effective long-term condition management. It states that we need peer support, support from other trained professionals, information about HIV treatment, information about healthy living with HIV, diet and lifestyle, and optimisation of general health issues. People living with HIV also need support around access to general health, financial advice, housing and employment support. This view is endorsed by NHS England, who argue, and I quote, "The effectiveness of HIV specialised services depends on other elements of HIV care being in place and effectively coordinated." And it should include the third sector HIV care and support services for treatment adherence, peer support and self-management. It should include social care, mental health and community services for rehabilitation, personal care or housing. Now, Madam Chairman, not everybody living with HIV requires support, and most will only need to use these services periodically, such as when they are newly diagnosed, experiencing employment issues, when they are pregnant, considering disclosing their status to others, or if they are experiencing discrimination. As for an example, the UK Stigma Survey identified that 28% of people diagnosed within the last 12 months reported suicidal thoughts. And sadly, the suicide rate for HIV-positive men in the first year after diagnosis is over 5 times higher than that of men in the general population. Similarly, when side effects of treatments have improved in recent years, many people still have real difficulty in managing them, especially when starting medication for the first time or transferring regimens. There are also people who are long-term diagnosed who experience ongoing and irreversible side effects of older HIV treatments, such as neuropathy, lipodystrophy, and most recently, there is emerging evidence on diabetes. Support services in these instances not only ensure that people have access to a trained professional or volunteer at the point of crisis, they also reduce the pressure on healthcare professionals. The National AIDS Trust reported that 50% of attendees at expert patient groups subsequently reported fewer GP visits. For an investment of £400 per attendee, there was an average net saving to the NHS for each patient with a long-term condition of £1,800. Positively UK also report that 88% of those reported, 88% of people reported that peer support has helped them to better adhere to their treatment plans. But unfortunately, we've heard from National AIDS Trust and other local HIV support organisations that HIV support services are vulnerable under the current Act because commissioning responsibility was not clearly defined. Therefore, clearly mandated service provision has instead taken priority, particularly where there have been reductions to public health grants for local authorities. Last year, for example, HIV services in both Berkshire and Oxfordshire were reduced by £100,000 between them. In Berkshire, this equates to a loss of a third of funding and will directly impact 300 people living with HIV in both Slough and Bracknell. In Public Health England's guidance to commissioners entitled Making It Work, HIV support services are the only part of the care pathway which has been left to be determined locally, as it states. This means that either the CCG or the local authority can provide them, but in a number of instances it appears no one is commissioning services such as community-based HIV clinical nurse specialists. The value of support services in other disease areas is well recognised. CCGs already commission cancer care and peer support for mental health services, and the Desmond, the Diabetes Education and Self-Management for Ongoing and Newly Diagnosed programme for self-management for diabetes. And as such, the APPG has recommended that the responsibility for providing HIV support services is met by NHS England and CCGs as part of the patient care pathway provided for long-term condition management. Madam Chairman, while local authorities do have a responsibility to provide public health and social care services, the ambiguity in the Act and reduced funding means that this responsibility has been deprioritised. Support services sit comfortably within the mandate which CCGs and NHS England already have to provide HIV treatment and care. And I think it's important what we're asking is that the Department for Health reiterate that we need a whole treatment plan from start to finish, which is mandated. Yes, of course.
Thank Martin for giving way. He's making some very good points, and I commend him for bringing an important debate today. Would you not agree with me, though, that one of the fundamental challenges that has been thrown up by the 2012 Health and Social Care Act is this fragmentation of services? And it's very strange to me as a clinician, and I made this point when I was on the Health Select Committee, that sexual health services are now commissioned by local authorities, and a lot of HIV diagnoses are, of course, first noticed or first discovered by contact with sexual health services.
My other friend makes a very good point, and I'll go on in my comments to identify what's almost like a lottery or a roulette of where you can have access to testing if those parts of the health service or social care services that you come into contact with know what to do. And then I will go on to comment about how the other problem is that some people, particularly GP services, feel they're under so much pressure, they don't always know how to refer people for testing. And some of the implications of gum clinic and the rationalisation of gum, can never get the full title, genitourinary clinics, known as gum clinics, are being rationalised, where people have the risk of falling through the cracks. So my old friend makes a very good point that because the services can be provided in a number of places by a number of parts of the health service with no clear responsibility for who does what, there is a great danger for other people thinking someone else is doing it or someone else is paying for it, and we end up with no one doing it or no one having the funds to do it. Which leads me on to, I was just going to go on to the point of the potential separation of sexual health and HIV services. Civil society groups have highlighted that some HIV services are being separated from sexual health services, which seems to have an unintended consequence of the Act, creating different commissioning responsibilities for different aspects of caring for people living with HIV. HIV clinical services are commissioned by NHS England. HIV clinics have traditionally sat within or next to sexual health or genitourinary medicine, gum clinics, because it's a logical place for them to be. It helps with referrals and the continuation of care, because most HIV diagnoses are picked up during routine sexual health checkups. And if I could, Madam Chairman, give an example, the Marlborough Clinic, based at the Royal Free Hospital, which serves my constituency, the team offer HIV testing and treatment alongside sexual health advice, STI testing and treatment and contraception services. Where there is an HIV positive diagnosis, the staff can quickly link the newly diagnosed person into care at the adjacent Ian Charleston Day Centre, almost walking them from one part of the building to the next to ensure that there was a continuation of care and not a gap between being diagnosed and referred, because any part of the health service, whatever the illness, whatever the condition, will tell you if there is a gap between diagnosis and referral to a specialist service, some patients simply don't turn up. Having them co-located improves that continuation of care. And so the threatened dislocation or the merging of gum clinics away from HIV clinics is a cause of concern and feel would make the fragmentation worse. And this is because while local authorities are entirely responsible for providing sexual health services, they are not responsible for the entire HIV care pathway. And this has resulted in sexual health services being put out to tender without a plan for the HIV service. And this disruption of care prevents a real problem for keeping track of patients and ensuring they remain in the care pathway. And likewise, of course.
Thank my honourable friend for giving way. One of the other practical problems of this that really wasn't thought very well in 2012 or in the run-up to 2012 is the issue, as my honourable friend says rightly, of communication between services, because very often the IT systems in the NHS don't talk to each other very well, but they certainly don't communicate very well with information that's stored about the same person in local authority databases or indeed those of private sector providers. And this is at the very core of the problem. And I'm wondering my honourable friend may, in his future recommendations to the Minister, look at that specific issue.
My own friend makes a good point. In fact, one of the informal reports the APPG is currently looking at is the future of social care, because HIV is no longer a death sentence and is a condition that is manageable. We are now getting people who are living into an age where they're expected to be dead, or the health service expected them to be dead. And the social care, we've got some early indications that the social care sector is simply not geared up for handling admissions, if that's the correct word, or placements into care homes and nursing homes of HIV people, and finding that some of the care workers are simply uneducated as to how to provide support. And so you're right, as we move people into the private placements, whether they are funded by the local authority or self-funding, we will have that problem of a lack of joined-up support, not just on IT, but if it's falling between social care, again, a local authority responsibility, and a health condition, which is responsibility perhaps of an HIV clinic supported by the NHS. So my honourable friend makes a very good point. And in terms of the talking about this integration between keeping the HIV and sexual health together, the disruption of dislocating those two clinics prevents a real problem for keeping track of patients, I think, as I've said, because it's that having that co-location ensures that they stay within the care pathway. And integrating HIV within sexual health service supports young people living with HIV as they transition away from paediatric care into adult services. Navigating adult services for the first time can be challenging enough for young people, so including it alongside sexual health services ensures they have a one-stop shop for their HIV care and other tools for ensuring good sexual health. And in many cases, elsewhere, the reality is that sexual health has become fragmented away from HIV because sexual health is the more profitable aspect of sexual health tenders, and therefore some providers have only purchased the sexual health service, leaving no provision for HIV. Madam Chairman, in their oral evidence to the APPG last year, the British Association of Sexual Health and HIV, BASH, believe this to have been a genuine oversight of the tendering process. And what they said was, I don't think the connection of what would happen if, particularly in a small service, the sexual health element of the tender was won by another provider. I don't think anybody thought what would happen to the HIV service that was there. I think they thought it would just continue to be provided. And of course, that may well be the case if it's a large HIV unit. But in many cases, it isn't. And it's financially not viable, and that's where the problem lies. Others have reported that when sexual health tenders were purchased without the HIV service, HIV clinics have been left understaffed and with little certainty around the commissioning of the HIV service. And this has meant that people living with HIV have been required to access services elsewhere, which has led to small but significant numbers being lost to care. In their written evidence to the inquiry, BASH also noted that in a sexual health service that went out to tender a few years ago, the contract was awarded to a community NHS provider. The outreach HIV clinic that had been well established was not sustainable, and the service was discontinued. The majority of the service users transferred their care to other HIV providers some miles away, but 9% were presumed to have disengaged in care. With this in mind, the HIV Puzzle report recommends co-commissioning of HIV and sexual health between local authorities and NHS England, with the two commissioning bodies working collaboratively to ensure a service assessment is in place so that whoever the new provider is, they have a responsibility to ensure that the HIV service is maintained and not lost. The Department of Health needs to ensure that there is mandatory guidance for sexual health service bidders to undertake risk assessments and produce action plans dealing how the HIV treatment service will be transitioned and implemented. The separation of HIV from sexual health clinics is an unintended consequence of the Health and Social Care Act, but it needs to be addressed. The split responsibility for different aspects of HIV care between local authorities and NHS England is leading to confusion in commissioning. And early indications suggest that a small but significant proportion of HIV patients have fallen out of the care pathway as a result, as I've mentioned. Previously, sexual health was all commissioned by PCTs, and the separation of HIV from sexual health was unheard of. Aside from the unintended separation of services, another contributing factor was also covered by the inquiry. This is that there remains no whole service specification for HIV and sexual health, and this, we believe, is causing a deprioritisation amongst health professionals. The service specifications that do exist relate to either sexual health or HIV services through integrated sexual health services, national service specification, and the NHS England service specification for adult HIV services, and the same for paediatric HIV. While all of these guidelines are useful, What is really lacking is a comprehensive service specification for HIV and sexual health that encompasses all aspects of the HIV care pathway. That is why we have recommended that the government develops a whole service specification for HIV and sexual health, bringing together the various strands of clinical guidance which already exist to ensure there is clear and consistent advice to all local authorities, CCGs and NHS England. A clear service specification for HIV and sexual health would mean that there is a one-stop shop for local authorities or CCGs, and this would help remove the sense of fragmentation experienced by both patients and health professionals. While we recognise that public health is a devolved issue, the Secretary of State must ensure that local authorities have enough guidance to ensure there is a minimum service requirement that they must provide. At the moment, the Act is not providing enough clarity or accountability to any one commissioning body. The nature of HIV as infectious disease means that HIV services do not start at the point of diagnosis. Madam Chairman, let me turn to testing and prevention. Prevention and testing are a critical part of encouraging safe sex, and the APPG is extremely pleased with the government's recent announcement that RSC will be made compulsory in all secondary schools. Properly informed and sensitively taught, this will go a long way to ensuring that young people are able to make informed decisions about safe sex and preventing the transmission of sexually transmitted infections and HIV. Nonetheless, testing and prevention are also subject to similar fragmentation of commissioning responsibility, and therefore confusion over commissioning responsibilities remain. As an example, HIV testing can be paid for by all three commissioning arms, the local authorities, NHS England and CCGs, depending on what setting and context the test is offered. HIV testing, including community outreach for most affected groups and routine population screening in areas of high prevalence, is the responsibility of local authorities. But HIV testing, when clinically indicated in a hospital setting, and termination of pregnancy services paid for by CCGs. So you have one group on outreach in high prevalence areas being dealt with by local authorities. You have where it's clinically indicated in a hospital, or perhaps where termination of pregnancy services, where it's paid for by CCGs. And testing and treatment for STIs, including HIV testing, provided in a general practice when clinically indicated or requested by individual patients, is covered by NHS England as an essential service under the GP contract. Different settings, different funding, total confusion. In short, if someone is offered an HIV test by a hospital doctor because they arrive with shingles in A&E, it is paid for by the CCGs. If they are offered the same test for the same reason by their GP, it's paid for by their NHS primary services contract. And if they are offered a test by the same GP simply because they are living in an area of high prevalence, as NICE recommends, it's paid for by the local authority. The evidence for prevention and early diagnosis is overwhelming. People living with HIV can expect a near normal lifespan if they are diagnosed early, but people diagnosed late with HIV continue to have a tenfold increased risk of death in the year following diagnosis. NICE also estimates that the cost of HIV care remains 50% higher for each year after diagnosis if the diagnosis is late. Likewise, prevented onward transmission is crucial, not only for individual and public health, but the sizable lifetime costs of treatment. In 2011, PHE estimated that each infection prevented would save between £280,000 and £360,000 lifetime treatment costs. NICE estimates that if national testing guidance was implemented fully, 3,500 cases of onward transmission could be prevented in the next 5 years, saving the NHS over £18 million per year in treatment costs. I'd mentioned that GPs say that their time is under pressure, and it's widely reported in a number of health issues as a barrier to proper intervention. and that includes the availability of education for GPs on offering HIV tests. That remains a problem where GPs feel they simply don't have enough information about the most appropriate time to intervene on HIV testing. As the Royal College of GPs note, there is the issue of effective implementation, including training and support for practices to adopt these schemes. GPs and our teams are already under immense resource and workforce pressures, making it incredibly difficult to implement any new programme. And many in primary care will therefore refer patients to GUM services for testing, but this has the potential to entrench existing inequalities in late diagnosis rates, given that high-risk communities, particularly Black African communities, are far less likely to access sexual health clinics and much more likely to access primary care. While healthcare professionals' knowledge of when to offer an HIV test is not directly related to Health and Social Care Act, the expectations from patients and the NHS England mandate commissioning testing based on clinical indicators mean educating healthcare professionals on the subject in line with NICE public health guidance must be a priority. Madam Chairman, the APG has also called for protection of local authority public health grants from further funding reductions, in line with the Government's commitment to ring-fencing the NHS budget. And I would be grateful if the Minister could outline what plans she has to ensure that public health investment is not lost under further changes to local authority funding. And finally, arguments over commissioning responsibilities has led to a stalemate over the introduction of innovation in HIV prevention. In 2015, studies from UK, France and the US reported that when taken regularly, PrEP can reduce the risk of HIV transmission by up to 86%. And as the National AIDS Trust notes, PrEP is exciting, new and currently unique. It is not a vaccine, although it has a similar impact. We can draw comparisons to statins in terms of preventing illness or contraception, in terms of prevented unwanted consequences of sex. But actually, there is nothing quite like it. It is the definition of healthcare innovation. I do not wish to repeat the arguments made for and against the centralised commissioning of PrEP, but it does serve as an important case study in highlighting how the fragmentation outlined already risks HIV services, which are focused on both lifelong condition management and preventing onward transmission. As I mentioned at the beginning of my comments, I'm enormously grateful to the Minister and NHS England for the announcement of an expanded clinical trial phase, including at least 10,000 participants, that will be launched early in 2017-18. And I hope that she'll be able to update us on this trial as part of her response. Madam Chairman, in closing, I would like to thank everyone who has participated in the inquiry, particularly those who travelled across the country to attend our oral evidence sessions, and all the members of the APG who took enormous time out of their diaries to support this inquiry. Thank you. The
question is that this House has considered the APPG report, Impact of Health and Social Care Act on HIV treatment. Sir Jim Shannon.
It's a pleasure to serve under your chairmanship as always, and it's a particular pleasure to hear the honourable gentleman for Finchley and Golders Green set the scene for us on a subject that's very close to his heart and one that he has become a champion for in this House, and congratulate him on being that. I've always been here to support him in his endeavours as well, and I'm very pleased again to do likewise. When we think of HIV, as we do, and through this debate we do, and through the report we've had as well, our thoughts automatically go to, in my case, go to African nations. Mine go to Swaziland as my parliamentary aide visits and supports an orphanage there, as 1 in every 2 people have AIDS, and there's naturally a massive need for care and support of orphans. My heart has long been touched, Mrs Main, with the needs of the people in this country who have been ravaged by the spread of AIDS, and the work of the World Health Organization and other charities such as Teen Challenge and Elim Missions, who are very active in my constituency. However, this debate today, Ms Main, is very clearly in relation to this report, and I believe it makes clear that it's an issue much closer to home, as well as an issue in Africa, and we can relate that to our own constituencies. And I understand that health's evolved for Northern Ireland, at least it is until we see how these talks process go, in which case maybe this minister might be the person making the decisions. We'll have to see what happens in relation to that. I hope, with great respect, Minister, you won't be making those decisions. I hope you'll be making them back home, but that's by the way. In Northern Ireland in 2015, there were 103 new diagnoses of HIV, bringing the total to almost 3 times what it was in 2006. And some of these figures, Ms. Bain, are quite shocking and quite worrying. That's the highest number of HIV diagnoses to ever be recorded in a single year in Northern Ireland. From the year 2000 to 2014, a total of almost 557,000 HIV tests were carried out in Northern Ireland. In Northern Ireland, a total of 126 people diagnosed with HIV have died. This includes the AIDS and non-AIDS related deaths, and the data obtained from the Public Health Agency showed that 114 pregnancies were affected by HIV from 2005 to 2016. But encouragingly, and this is, there's always a good message to be told as well. Encouragingly, the pregnancies in Northern Ireland were managed to prevent the infection being transmitted from mother to child. Quite innovative, Mrs. Bain, but very effective in how we have come forward with medicine and medication over the years. Certainly a bonus, and highlights the importance of knowing of infection and then managing the birth of the babies correctly. Across the UK, there were some 6,095 new cases. In total, during 2015, there were 88,769 people UK-wide being treated by or for HIV. This is not an African infection. This is a problem in the UK that we must address. And the Honourable Gentleman, in setting the scene for us, very clearly focused the attention, as it should be in this debate, upon where we are in the United Kingdom. 101,200 people were estimated to be living with HIV in the UK by the end of 2015. And the discrepancy between those in treatment and those who have the disease is found in the fact that, as with many illnesses, many people are living with the disease without knowing it. So I'm not sure, Minister, in the response whether you're able to, but I'd like to have some thoughts from you about how we reach that unknown figure of people out there who are carriers and perhaps don't at this moment know it. The clear fact is that if people are not diagnosed, then there is a much greater danger of unwittingly spreading the infection. It's estimated that some 87% of people are diagnosed. 96 of those diagnosed are accessing treatment. 94% of those accessing treatment are virally suppressed or undetectable. So the virus will not show up in tests, and people are unable to transmit the virus to others. That's some of the facts of the case. This means that around 13% were undiagnosed and unaware of their infection, meaning that they were not able to access care to protect their well-being and prevent the onward transmission of HIV to others. It's been estimated that each new infection costs the NHS between £250,000 and £360,000 in direct lifetime costs. And this alone is something I believe that we need to be able to address, and for the Minister to at least consider in the process of this debate. The number of new diagnoses in 2015 was slightly fewer than the 2014, but new infections have remained roughly static since 2010. The fact that we are having new infections each year is something we can't ignore and something that needs to be addressed. And again, I'm very keen to know from the Minister her thoughts upon the best way of perhaps doing that. So if I could ask her that as well. 37% of people are diagnosed late. This has a potential impact on their immediate health and therefore the cost of treatment at the point of diagnosis and beyond. The fact that they're diagnosed late would indicate to me, Ms. Bain, that there was a possibility of diagnosis earlier. And if that is the case and it hasn't been done, again, I would ask the question just why. There must be, I believe, a proactive approach to encourage screening and also reinforce the education and the learning aspects of prevention of spread of HIV and sexual health in general. I put down a question some time ago in which the Minister was the person who responded to it in relation to the increase in infection and sexual infection amongst those in the 50 to 70 age bracket. And the figures indicate that there's an infection rise amongst them as well. Again, I ask a question because it's important we do so. Just because you get to a certain age in life that you're not involved in those activities as much as perhaps you may have been in time past. But just to say that there is, I believe, an undercurrent of the rising of sexual diseases in that age bracket. So again, Minister, I know you responded to me way back in last year on this issue, but I would like to get your thoughts maybe up to date in relation to that. If I could also, some of the recommendations found in the 2016 report from the All-Party Parliamentary Group on HIV and AIDS into the impact of the Health and Social Care Act 2012 on HIV service are ones that I believe bear highlighting. And of course, the first of which for me is a recommendation referring to the fact that while public health has been devolved, the Secretary of State must ensure that local authorities have enough guidance to ensure there is a minimum service requirement which they must provide. And the Honourable Gentleman mentioned that in his introduction as well, and he very clearly outlined the issue. At the moment, the Act is not providing, I believe, Minister, with respect, enough clarity or accountability. And I believe it's the Department of Health's responsibility to ensure that it does. Again, look to the Minister, as I always do, very responsive Minister at this stage, and would ask what cooperation has been had with the regional devolved assembly in Northern Ireland and with the Health Minister there, and what plans are in place now to engage with the Secretary of State should the Minister, the Secretary of State or the Minister of State of Northern Ireland and should be returned to direct rule. We cannot afford for health to suffer due to the reluctance. I make this point, Ms. Main, just to say this reluctance of Sinn Féin to enter into government with the party with the largest mandate, which is ourselves. It is the responsibility of the Minister in this place to step in and step up if necessary and ensure that the people of Northern Ireland have the right strategies in place. I was quite encouraged in the background and the library information that we got, Ms. Main, and some of it's been extremely helpful. And I make the comment about the pro-exposure prophylaxis drug called Truvada. I think the Honourable Gentleman referred to it in his introduction. But there's some excellent medications that we have today, and that's one that, an actual fact, that it's a brilliant, new, innovative drug that can make a difference. It can save lives, can stop or detain or at least control HIV infection, and indeed gives longer life. So I think some of the things that are happening out there that which the NHS is providing in the Minister's department, I think we want to welcome that. Therefore, it really is tremendous news. I conclude with this comment, Ms. Main. Lastly, I would briefly highlight that it's clear that the Department of Health needs to ensure that there is no mandatory guidance for sexual health service bidders to undertake risk assessments and produce action plans detailing how the HIV treatment service will be transitioned or indeed implemented, and we need to have that in place. It is not enough, Ms. Main, to put a couple of adverts in the media with respect, although this is good, and it's good that it should be done, but it's not enough to do just that, and we must have a strategy in place to deal with the prevention of this disease. And remember that this is not something that is affecting any one nation. It is affecting us all in this nation of the United Kingdom of Great Britain and Northern Ireland, and we must all deal with it effectively. And again, I look to the Minister, as I always do, for the indication of how the Minister intends that this will be done. Thank you very much.
Well, thank you very much indeed, Mrs. May. Can I congratulate the Honourable Member for Finchley and Golders Green, both on securing this debate and on his and his all-party group's excellent report, and indeed for all of the work that he does on HIV and AIDS. And I should declare an interest at this stage of the debate, Mrs. Main, in that I'm a trustee of the Terence Higgins Trust, and I draw attention to my entry in the Register of Members' interests. He's absolutely right, and as is his report, when he talks about the impact of the Health and Social Care Act passed in the last Parliament. And as well as having read his all-party report, I'm sure the Minister responsible has also read the Health Select Committee report that we published just last year on public health in general and the impact of that 2013 legislation on the delivery of public health, but in particular on the delivery of sexual health and HIV services across the country. And the Honourable Member for Finchley and Golders Green is absolutely right that in our report we identified a number of problems and challenges with the new landscape and commissioning structure. But the areas that were suffering most, and we heard this from individual organisations up and down the country in terms of the evidence that we were presented with, from the HIV/AIDS organisations, from those who work in sexual health, the consultants, and virtually everyone else, that the areas that had been hit most negatively by the Health and Social Care Act and the changes in commissioning arrangements were HIV services and sexual health services more generally. And I think we all have our own ideas as to why that might be the case. But clearly, while I think in general the jury is still out about the decision to pass the responsibility for public health to local authorities, there were concerns expressed at the time of the Health and Social Care Act, and a number of us did raise our concerns about this and warn the then Health Secretary Andrew Lansley about the potential impact of giving local authorities the responsibility for HIV support services and other sexual health services. But I'm afraid those concerns weren't listened to. And I do hope the Minister, when she responds to this debate, I'll give way in a second, I do hope the Minister, when she responds to this debate, will explain to honourable members and to the country at large what monitoring the government has been doing of the impact of that Act on these services, and what measures or action the government will take as a result of anything they find. I give way to the honourable member.
I thank the right member for giving way and agree with very much what he said. But would he agree with me that one of the challenges that was thrown up and the problem lies in the fact that local authorities are now commissioning actually the provision of health services in complete isolation of many of the other HIV services and associated services, and that is very different to our general understanding of what public health is, and that was one of the core and the fault in that Social Care Act. Yeah,
I mean, I completely agree with the point he makes, and if you look at a table of where the different commissioning responsibilities lie for different bits of sexual health and HIV and AIDS, it's all over the place. And of course, on top of that, Mrs Mayne, although the government can, with some justification, claim to have defended, to have protected NHS spending in cash terms, if not in real terms, it cannot claim to have done that when it comes to public health. And public health has taken significant cuts and will continue to take significant cuts over the next few years. And of course, those are cuts that are being imposed on local government. And as you will know, and other members will know, local government is facing huge financial challenges across the piece. And there's also the threat, of course, of the withdrawal of the ring fence on public health funding in the next 2 or 3 years. And in our report, we made quite clear that we thought that was a very risky move indeed. So I hope that the Minister will both assure members here, I don't want to repeat a lot of what was said by the Honourable Member because he made a very comprehensive and excellent speech, but I do hope that she will explain to us what monitoring the government is doing on the impact, what the government is going to do in response both to the concerns raised in the recommendations of the all-party report and our select committee report to address the problems that we have raised, because we have now known about these for some time. Our report is now, I think, over a year old. And also, I'd be grateful, very welcome news about PrEP, but I'd be grateful if she could give some clarity about the timing of the commencement of that trial. And while we're on the subject, Mrs Mayne, another potentially very welcome development is the big fall-off in HIV presentations or positive tests at some of the London clinics in the last few months, which some people are suggesting may be to do with the availability of PrEP. And I wondered if the Minister could tell us whether she has made an assessment as to whether that is the case, in which case it's a very promising development indeed. And finally, one of the things that particularly concerns me in this area at the moment is the plight of older people living with HIV and AIDS. Around a third of the people in Britain now living with HIV and AIDS are over 50, and about 60% of those live at or below the poverty line. And one of the reasons for that, of course, is that for many of them, when they were originally diagnosed, they didn't expect to have a particularly long life expectancy, but thanks to the fantastic treatment and care that has been invented and developed, that has helped not only keep people alive, but enable people to lead lives of reasonable quality. Back then, they may have been less cautious about spending the money they had to get by at that time, and now they find themselves hopefully with many years stretching ahead and no more means at their disposal. So there is a particular challenge when it comes to older people living with HIV and AIDS, and this will require the Health Department to work more closely with the Department for Work and Pensions, because some of the people that certainly my charity, the Terror Seekers Trust charity, deals with are facing real problems when it comes to benefits and benefit sanctions and those sorts of things, which add extra pressure and extra misery to the challenges they already face as people living with HIV.
Can I apologise for arriving late to the start of this debate? It was because I was waiting to get in on the statement from the Prime Minister, so I do apologise for that. It is a pleasure to serve under your chairmanship again. I long for the day when I can get called as quick in statements as my Rotherham friend, the member for Exeter, who gets called with such speed and alacrity. Well, I long for that day as well, but that's in the lap of the electorate, not with me. Can I also thank the honourable member, the member for Finchley and Golders Green. Not only is he heading up some incredible work for the all-party group, which has provided some remarkable pieces of information, concise information which is usable not just within the sector, but usable by a great number of people to advocate for the challenges of people living with HIV and AIDS, and also to do so and help explain the broader issues facing people. And I know that these are the kinds of reports which are read by a great number of individuals, not just people who are experts on the subject, and that's a credit to him. His wide-ranging speech for the last 3 quarters that I caught was exceptional, and I'm very grateful to have been here for it. I represent a city, the city of Brighton and Hove, which has more than 4 times the national average for contraction rates for HIV and people living with HIV. This places an additional onus on me to give voice to both the sector and the individuals who are living with this long-term condition. It's as part of being a representative of that city, but also previously as part and a representative of the gay community when I was on the board of Pride and so forth. I spend a lot of time trying to understand the fabric of the support services going to people living with HIV, and have done so even more and with even more enthusiasm and dedication since being elected as the MP. And I'm very proud that we have some incredible preventative work going on in Brighton and Hove. The work of THT and Stonewall, but also local groups, which is coordinated through the LGBT Forum, has done some really remarkable work on prevention. It is a sadness that they don't have all of the tools at their disposal for which they're calling, and by which I am talking about PrEP. I know that these issues have been aired by other members here today, so I won't go on in any more detail than that. But it is something which the grassroots and the people working in the front line down there in Brighton and Hove are calling for absolutely enthusiastically.
Would my honourable friend give way?
Of course I would.
I thank my honourable friend for giving way, and I also wish to add my thanks to the honourable member for Finchley and Golders Green. But I ask, would my honourable friend agree that having such a confusing and complex mix of commissioners and authors of standards for prescribing does not help establish consistent commissioning of drugs such as PrEP, which he has mentioned, which would help so many people, not just in his own constituency, but also my own of Bristol West?
I'm grateful for the intervention because Bristol and Brighton share many of the same characteristics in terms of demography, but also the numbers of people who are living with a long-term condition of AIDS, HIV. And I agree with her wholeheartedly. I think the member for Finchley and Golders Green very well made the point about the split that was created in the Health and Social Care Act. It is impacting communities, and I hope very much that ministers will finally realise this is something that needs to be prioritised going forward. I have also learned in the work that I've been doing with people who are delivering frontline services that the people living with AIDS, HIV very often have very complex needs. And the landscape for provision is also very complex. It moves from prevention to treatment, but now also, as my right honourable friend, the member for Exeter, mentioned, it is people living into old age with HIV. And this is something which is not entirely new, but it is a fairly recent and something development which we should celebrate the fact that there are people now living into old age with HIV, but it does present us with some very complex challenges and our health service accordingly. I too have now met people who are living into their 70s and 80s with HIV who were, when they were first diagnosed, pre-1996, given just weeks to live. So there is an additional challenge for these people, as hinted at by my right honourable friend, and that is that many of these people are also not only vulnerable because of the comorbidities that they may have, and also the complex health challenges they have, both physical and emotional, but very many of them did spend all of their money when they thought that they had a very, very short time to live. So they're also additionally vulnerable because of their financial position. This means that these individuals need the kind of holistic care to which they are deserving. Now, the Honourable Member for Finchley and Golders Green very well talked about the split created by the Health and Social Care Act. I have seen how this is impacting directly the provision of support for people living with HIV, and that some people are simply failing to get the comprehensive care that they need. It is leading to two situations: individuals with complex needs not getting the comprehensive care that they need, but providers of comprehensive care not getting the funding that they need to provide the services. And it is this which is causing a terrible ruction within the provider landscape for HIV right now. Specifically in Brighton and Hove, I'm talking about the Sussex Beacon. And I'll talk a little bit more about it in case the Minister isn't aware of the fantastic work done. But before I do so, it's important to talk about the general health landscape in the city of Brighton and Hove, because it is a health landscape that is in crisis. We have a hospital in special measures. We have a CCG in special measures. We have an ambulance trust in special measures. We have patient transport services, which are privatised, botched and renationalised, all within 6 months. And on top of it all, we've had 7 GP surgeries closed within the last 12 months. It is a service which is comprehensively in crisis. However, we have one jewel in the crown, and that is the Sussex Beacon, which was established in 1992 as a hospice. It was established to provide end-of-life care for people who were dying because of HIV and AIDS. Now, that has flourished and evolved as the needs of their client group has changed and evolved over time. It is a remarkable organisation. It provides preventative services. It provides outpatient and inpatient services. It provides more than 2,000 bed nights each year. CQC just last year said that the Sussex Beacon is outstanding. It is one of the true beacons of health in our community, and I'm proud that it exists to provide comprehensive, holistic, and tailored care for individuals living with HIV. It is something that is incredibly important to our community. But due to the split, no one agency is taking overall responsibility for its funding anymore. Not the local authority, and not some of the funding agencies designated to do so by central government. As a result, its funding has fallen by £400,000. Statutory funding has fallen by £400,000 a year. It is a funding gap that is bringing an extraordinary organisation to its knees. In Brighton and Hove, we have a rainbow coalition of politics. We have 3 MPs, each from different parties. But last year, we united to come together to write to the Health Secretary and, additionally, with the Leader of the Council, to point out not just how extraordinary the work of the Sussex Beacon is, but to point out the dangers of what would happen if all of their client group is transferred from outstanding into special measures, into a hospital which is struggling to cope with the people it has at the moment, and to deal with people with extremely complex needs, people who are used and deserve to specialist care for their specialist challenges that they face. Now, sadly, the Health Secretary, who took time to come to Brighton to visit the Sussex Beacon for a photo shoot before the election, along with the Prime Minister, who came at a different time, and she took time out to come and visit and have a photo taken at the Sussex Beacon, neither had time to respond to the letter about the dangers this service faces going into the future. The letter was passed on to another agency in another part of the Department of Health to respond to. Now, we have the situation where perhaps people felt we were crying wolf. We were not. The trustees of the Sussex Beacon have now issued a warning that they will start shutting down services from June this year, unless the funding gap is closed. Staff have been put at notice of redundancy. We are really in the last chance saloon for this fantastic organisation, which is celebrated beyond Brighton for the services that it provides. And I urge ministers to specifically look at the challenges they face, because to get something which is so complex, providing such complex needs, to outstanding in today's health environment, the Minister will know what an achievement that is. Because of the nature of this debate, she will know that the people who are using the services count on it in a really heartfelt, emotional and dependent way. It is an extraordinary service. So can I urge ministers and the Minister to take a look directly at this challenge and what government can do, because once this service is lost, it will be gone forever and it will not be coming back. And I think I labour the point for two reasons. Clearly, because I am a Member of Parliament and a patron of the Sussex Beacon and a Member of Parliament in the area served by the Sussex Beacon. But secondly, in the context of this debate, it speaks to the challenges that comprehensive providers are facing in an environment where funding has become very, very specialist and very, very narrow. Comprehensive providers are really struggling to find their feet in this new environment. So what is happening to the Sussex Beacon speaks to the broader challenges faced by the sector within the broader health environment. Thank you, Mrs May.
Hear, hear, hear.
Martin Day.
Thank you, Mrs May. It's a pleasure to serve under your chairmanship and take part in today's debate. I'm also grateful for the Honourable Member for Finchley and Golders Green for securing the debate and for his detailed and informative speech, and indeed for the work of the APPG on HIV/AIDS in producing an excellent report, the HIV Puzzle, which, based on the evidence presented from charities, civil society groups and pharmaceutical industry, notes significant upheaval to HIV and sexual health services since the Health and Social Care Act of 2012 was implemented. The findings of this report are very worrying. A joined-up multi-sector approach to support and care for those at risk of living with HIV is crucial to its prevention. The UK Government should seriously reflect on how it can improve HIV services in light of this body of evidence. While this report is concerned with HIV services in England, its findings will be of interest throughout the UK. Communicable diseases don't, after all, recognise administrative or national borders. And the APPG report recognises that in Scotland, sexual health sits under the blood-borne viruses in the health system, which Dr Gordon Scott argues makes it easier to set priorities. So in that spirit, as a Scottish member and on an issue which is devolved, I hope my comments regarding HIV in Scotland will also be of interest to members from other parts of the UK. We know that there were 6,095 new diagnoses of HIV across the UK in 2015, and 300 of those were in Scotland. The latest figures for NHS Lothian, which covers the West Lothian part of my constituency, tell us that we have 1,589 people diagnosed and living with HIV, and 70 of those were diagnosed in the last year. At the other side of the country, Glasgow has experienced its biggest rise in HIV infection for nearly 3 decades. This is an issue which will affect every community in the country. We all have our challenges, especially when we consider that perhaps around 13% of people are estimated to be undiagnosed, and with all the consequent risks of onward transmission which that brings, as well as the impact on the people themselves from being unable to access care and treatment. Lifetime treatment, of course, as we know, costs the NHS between £280,000 to £360,000 per patient, a not insignificant amount. Prevention of HIV infection remains a priority for the Scottish Government. There is absolutely no room for complacency on communicable diseases such as HIV. And we continue to provide funding for NHS boards for HIV prevention, as well as supporting organisations such as HIV Scotland, with £270,000 in funding this year. There is, of course, no one-size-fits-all approach to HIV prevention, and that is why in Scotland we are also providing Waverley Care with £45,000 in funding for this year for their work in HIV prevention and support with the African communities. A joined-up approach to HIV care is vital to ensuring that people infected can get the care they need to live life as independently as possible, and the Scottish Government's sexual health and blood-borne virus framework 2015 to 2020 is continuing to build on its achievements made in its original framework document of 2011. The HIV testing kit and services revocation Scotland regulations of 2014 have lifted the ban on the sale of instant result testing kits in Scotland. In light of this change and following leadership on the issue by HIV Scotland, a subgroup of the Executive Leads Group published a Questions and Good Practice document on instant result self-testing in March of 2014. The Good Practice document was the first of its kind in the world and has since been recognised internationally as an example of good practice by the World Health Organisation. All NHS boards in Scotland have protocols in place in relation to HIV post-exposure prophylaxis, or PEP, for sexual and non-sexual exposures. The framework makes clear the importance of a multi-agency approach to sexual health and blood-borne viruses. To truly deliver on the framework outcomes in the long term will require involvement of patients and service users, NHS boards, local authorities and the third sector, academics, media and indeed the general public at large. The integration of health and social care in Scotland is one of the most significant reforms since the establishment of the NHS. We're the only UK nation to have legislated to put NHS boards and local authorities under statutory duties to work together. This is helping to tackle priorities within the framework and to work towards as joined up as possible an approach to care for people with long-term conditions and disabilities, such as HIV. Evidence generated in late 2014 and early 2015 indicates that the HIV infection has been transmitted among a small population of highly chaotic, vulnerable and often homeless people who inject drugs. Such transmissions reinforce the importance of prevention work with such populations. The Scottish Government is working with health boards, schools and the police service to ensure that vulnerable groups can get the right support to prevent and treat infection. And the framework update includes commitments regarding development of care services with local authorities, tackling social stigma through education and encouraging regard for HIV testing as routine, NHS boards and partners offering testing to vulnerable groups using innovative approaches such as delivering testing in the communities themselves. And the Scottish Government are also considering the recommendations of an independent review of PrEP. The European Medicines Agency have granted a licence for Truvada for PrEP for HIV in adults at high risk, and the Scottish Government's Chief Pharmaceutical Officer has written to its manufacturer asking them to make a submission to the SMC. The Scottish Government's position is that all medicines must be licensed before they can be made routinely available on the NHS. But we recognise that some people are already buying PrEP drugs privately in Scotland. It is important that people doing so receive appropriate advice and monitoring from clinicians. The Sexual Health and Bloodborne Virus Executive Leads Network are considering the findings of the PrEP Short-Life Working Group, which considered a range of issues associated with the use of PrEP, and I look forward to hearing its outcomes. So in conclusion, I would commend the work of the APPG and its report on the issue, and there are undoubtedly lessons for us all within it. Thank you.
Thank you, Mrs Mayne. It's a pleasure to serve under your chairmanship this afternoon. Firstly, I want to start by thanking the Honourable Member for Finchley and Golders Green for securing this important debate this afternoon and for his excellent chairmanship of the all-party group on HIV and AIDS, as well as his comprehensive opening speech. It really was a tour de force of the issue, and I thank him for that. I also want to thank the other honourable members who contributed to the debate this afternoon, the honourable members for Strangford, Linlithgow and East Falkirk, and my honourable friends, the members for Exeter, Hove and Portslade and Bristol West, for their excellent and knowledgeable speeches and interventions. I know they will have all given the Minister a lot to think about today. Whilst we've come a long way since the height of the HIV/AIDS epidemic of the 1980s, this does not mean by any stretch we should be complacent in our approach to this disease now. Across the UK, it was estimated to be 101,200 people living with HIV by the end of 2015, with 87% of those with a diagnosis and 96% of those diagnosed accessing treatment. Whilst this is a minority of people in the wider population, it is a significant minority that we cannot let down when it comes to their care and treatment. The number of people receiving HIV care in 2015 in England was just over 81,000. This is a 73% increase in the number of people accessing HIV care since 2006. In part, this is welcome, as this means more people are accessing care than that can improve their lives, but it also provides us with reasons to ensure future quality of care provided. And this is the crux of why we are here today to debate this issue. As the Honourable Member's APPG highlighted, it is understood that since the passing and implementation of the Health and Social Care Act 2013, there have been growing complications with the commissioning and provision of HIV services across the healthcare system. In my contribution to this debate this afternoon, I will touch upon the Health and Social Care Act's impact on HIV services, but also expand into other areas such as the cuts to public health budgets and the worrying trend of decommissioning of HIV services, and finally touch upon issues regarding PrEP. Since the passing of the Health and Social Care Act, there's been a significant fragmentation of our NHS and wider health services. During the passing of the Act, we on this side of the House felt it was an unnecessary top-down reorganisation. And the case of HIV services proves exactly how this fragmentation is causing consequences for the future of these vital services. What the creation of CCGs and the devolution of public health to local authorities has done is fragment HIV services across various bodies with no coherent commissioning and oversight. Currently, services are failing to maintain a standard that patients expect. This is down to commissioning responsibility not being clearly defined under the Health and Social Care Act. Whilst the coalition government argued that the Act was to ensure the streamlining of services, the opposite has clearly been the case for HIV services. Therefore, I want to push the Minister on what she is doing to look at the APPG's recommendations, especially around joint commissioning for support services by NHS England and CCGs, along with co-commissioning of HIV and sexual health services between local authorities and NHS England. Another issue that the Minister must look at, and she knows this is something I repeatedly raise with her, is the issue of public health funding. The cuts to services further exacerbate the problems HIV services currently face due to commissioning responsibilities being unclear and pushing services to walk away from their responsibility because of this. I know the Minister will reference the funding going into regular HIV testing and the promotion of safe sex, along with the HIV Innovation Fund, but the impact on funding cannot be ignored. As last week, the National AIDS Trust published a report which showed that in England there has been a 28% decrease in the expenditure between 2015-16 and 2016-17. This is on top of the cuts to HIV support services or decommissioning of said services happening in Lambeth, Southwark, Oxfordshire, Portsmouth and Bexley. Whilst public health budgets are only one part of the funding streams for HIV support, treatment and care, it is nevertheless an important part of the pathway, as cuts to sexual health services more broadly are detrimental to HIV care. The £200 million in-year cut and the 3.9% cut year on year will only have a negative impact on the future of all sexual health services, including HIV. And the Minister must seriously address this false economy or risk seeing a public health crisis that could have easily been avoided.
Yes. And thank my honourable friend for her excellent speech. And I just want to reiterate, add my support to what she's just said there and maybe go a bit further. I would just like to know whether, would she agree with me that the Minister needs to clarify that a failure to address in preventative services is only going to store up costs and problems further down the line, and that when we have cuts to public health grants, they really need to be protected or ring-fenced or something so that we're not storing up problems for the future?
Hear, hear.
Thank you, Mrs Min. Thank you for that helpful intervention. I do agree with her, absolutely. The whole point of preventative services, of which the HIV and sexual health services are preventative, is in order to save money and lives further down the line. And this is something that we, together with the Minister, we debate this quite often in this chamber on other issues and preventative measures with other health issues regularly. But with regard to the future of HIV services, there still is a question mark above them, not only with the cuts we are seeing now, but also the future of public health budgets after 2018 not being guaranteed, along with issues with the devolution of business rates to local authorities, which will then be used to fund public health spending. The Government is still yet to publish details of how it aims to ensure that public health continues to be prioritised when this comes into effect, and I hope that the Minister will be able to offer further clarity today. Finally, I want to touch upon PrEP. PrEP is a highly effective way of protecting someone who doesn't have HIV from contracting it. As the UK Proud study showed, it was 86% effective in preventing HIV transmission, and if taken correctly, it is closer to a 100% success rate. That is why it's important that this drug treatment is supported as much as possible. And whilst the announcement on the feasibility study is to be welcomed, there remains questions that the Minister must answer. After nearly 4 months since the trial was announced, we are still none the wiser as to when it will begin, other than it will begin in early 2017-18 financial year. I welcome that in her letter to the APPG yesterday, the Minister said that this trial will begin in the summer, but I do hope that she will be able to offer some further clarity on when we will know more. There also remains an issue with the drug Truvada, which is used in PrEP. For the trial to reach the 10,000 people it plans to, there will need to be a generic version of Truvada used. Therefore, I would be interested to know what conversations the Minister has had with Gilead and how cooperative they have been to ensure the success of the trial. Finally, I want to ask the Minister about the concerns that will see many proud participants run out of their supply of PrEP this week, and will see between 350 to 4,000 individuals at highest risk of HIV running out of supplies. This is a matter of urgency, and the Minister must address it as a matter of priority. We cannot allow for those people who take this drug treatment to be put at risk. Therefore, I hope the Minister will go away today and look at this immediately. These are issues of very high importance to many people who live with HIV or within those communities where infection rates are more common than others, as we heard from my honourable friend with Hove and Port Slade and Bristol West. I was shocked and surprised to hear it's 4 times the normal rate of people in other communities in his. And so, you know, I'm well aware why he will be here today to speak for his constituents. So the Government's mismanaged approach to the structures of the NHS and wider health services is seeing services fall through the gaps and people's lives affected, which is exacerbated by these short-sighted cuts. It's important that we recognise the work that has already gone into addressing HIV in our society, but accepting that we still have a long way to go. We cannot squander these opportunities, as what we could see is yet another public health crisis due to complacency and failure to step up and address this issue. So I hope the Minister has listened carefully to all of the contributions to the debate, to the seriousness of this debate today, and will go away and do the right thing by the tens of thousands of people living with HIV or those at risk of contracting it, and support them. They should not be let down.
Hear, hear. Hear. Thank you, Mr. Mayor. It's a pleasure to serve under your chairmanship, and I would like to congratulate the Honourable Member for Finchley and Golders Green for securing what is a very important debate, and to all members who have contributed in what has been a very highly informed debate. I do welcome the opportunity to discuss the findings from the recent very interesting report, The HIV Puzzle, produced by the All-Party Parliamentary Group on HIV and AIDS. And I would also like to pay tribute to my honourable friend for his work on HIV innovation, and to all the members of the APPG for the work that they do to champion HIV within Parliament. Preventing the spread of HIV and supporting those who already have the disease remains a government priority. And as colleagues in the room will have heard me say before, when we look back at the HIV epidemic in this country, and as the Shadow Minister has also said, we can be proud of our achievements so far. In particular, we have made considerable progress in recent years towards meeting the UN 1990 ambitions to eliminate HIV-related mortality and transmission by 2020. We have already met 2 of the ambitions, with 96% of people diagnosed with HIV receiving antiretroviral treatments and 95% of those treated virally suppressed. And we have made significant progress on the 3rd goal, to reduce undiagnosed HIV so that it is over 90%. The proportion of undiagnosed cases was 13%
in 2015, which means we have seen a fall of almost half, from 25% in just 5 years. But that is still too high, and we do need to redouble our efforts to ensure that those who are positive receive timely diagnosis. And the Right Honourable Member for Exeter was absolutely right, that we must have robust monitoring to ensure that we do understand what is happening. And he has identified a particularly encouraging report from London. There's been reported during 2016 in some London clinics, particularly in Dean Street, and these trends are very welcome. Public Health England are actively investigating them, particularly whether this reduction has also been seen in other parts of the country and in other risk groups. They will report on this when the 2016 HIV data is published later this year, and I shall be happy to notify him if he would find that helpful. But as we have heard today, concerns have been reported by many members about public health funding in the future might affect the provision of HIV prevention and support services. And in line with recommendation 6 from the report, we have decided in relation to this aspect of public health funding, but wider public health funding as well, to retain the ring fence on public health grant for a further year until 2019 as we move towards the implementation of local business rates retention. This is a step on the way to a more locally owned system, but it will help smooth the transition by providing certainty for the next 2 financial years. This means that grant conditions will continue to apply, and Public Health England will have a clear assurance role in relation to grant spend. But I do recognise that local authority funding remains tight, and the councils have tough decisions to make to ensure that vital public services remain sustainable. And returns from local authorities have identified over 82 million was spent on sexual health. But yes, I shall.
Dan Portsmouth.
And for the constructive approach that she takes in replying to this debate, as indeed she does in all debates on health matters. But would she, just in terms of the funding formula, recognise that there are areas with very high demographic change, and some of those areas have higher rates of HIV, people living with HIV, and that actually that funding formula is beginning to be out of date and needs to be reviewed, and there's some parts of the country that need more money than that funding formula makes available for public health purposes.
Well, I'm going to come on to what we're going to do in the future, if that's okay. So the current situation will remain in place for 1 year, but we have identified the public health spend. A significant proportion of the funding will be allocated to HIV testing and prevention activities. But as the honourable gentleman, my honourable friend, points out, we also recognise that there are reasonable concerns about the practicalities as we move towards business rates retention and how this will work in practice, in particular with relation to health. But the fact is that the only way that we're going to get the scale rate is if we continue to engage closely with you. And one of the ways in which we're looking at it is how we manage the move towards mandation, how we look at transparency and accountability in public health spending. And we will be doing that in a very consultative way going forward. I shall.
I'm so sorry to interrupt the Minister. And just a minute ago, I think the Minister mentioned something about protecting public health funding for 2 years until the introduction of business rates, the change to business rates. I'm so sorry, I missed that point. Could she possibly clarify? Does she mean that this is a new announcement of new protections?
The public health ring fence will remain in place until 2019. We also recognise, as recommendation 1 makes clear, that HIV support services are an important part of the overall care that people diagnosed with HIV receive to support their health and well-being. I've heard your concerns today about the examples where these services are being decommissioned due to budget pressures, and we are increasing our focus on supporting and improving place-based commissioning, and we will work to provide the right opportunities for all commissioners and providers involved in the care pathway to work together to secure the right service response for the needs of the local population, taking into account each partner's responsibilities. And in line with a number of the recommendations, we also need to ensure that we make the most effective and efficient use of resources available. We are already seeing some really effective examples of this in the Public Health England HIV Innovation Fund, which is supporting voluntary sector-led projects across the country, which is focusing, as my honourable friend knows only too well, on HIV prevention and testing. This includes in Cumbria, where the outreach project is using community pharmacists to provide HIV testing in a rural area with very high rates of late HIV diagnosis, and the MESMAC project in Yorkshire, where they're providing HIV awareness training and testing at hostel housing migrants who are claiming refugee status in the UK. We're also encouraging innovations such as home testing, where our aim is this year to see 50,000 tests for HIV carried out at home, and they are already starting to make a difference. And of course, the introduction of compulsory RSE will, as my honourable friend says, have an important role to play in prevention. I was very sorry to hear the comments that the honourable gentleman made about the Sussex Beacon. I'm sure, given the account that he made of the very clear local need and the quality of the service, that he is holding local commissioners to account for their decision-making. But I'm afraid that my recollection is that I had responded to him on this matter, not an arm's-length body. So I'm very sorry if there has been any confusion on that matter, but I'm very happy to continue this discussion following the debate so we can clear that up and make sure that we can make some progress on the issue going forward, as I would not like him to think that we did not take it very seriously indeed. We all know that delivering high-quality HIV services is not just about funding, it is also about getting the commissioning right. As the report highlights, there is still a lot of work to be done to ensure that the commissioning landscape for the services supports effective collaboration and cooperation so that we can continue to see improvements to these and other outcomes. And that is exactly why Public Health England commissioned a sexual health commissioning survey, which very much supports the findings of both the Health Select Committee report and the report that we're debating today. And I recognise that the commissioning of sexual health and HIV services is complex, given the range of services and the different population needs covered under the broad umbrella of sexual reproductive health and HIV. And the risk of fragmentation damaging the progress that we have made is something that we are very alive to and we are working to address. And so I'm particularly pleased to be able to announce that Public Health England will be launching very shortly an action plan to support commissioners and ensure that they are able to provide sexual health and HIV services that their populations need. As their first priority, Public Health England will look for ways in which to reduce the fragmentation of commissioning and address the barriers which stop effective collaboration and cooperation between commissioners. This will include encouraging the development of a model of lead integrated commissioning in each locality, including developing models of out-of-area tariffs and other issues that can slow down contracts and increase costs. PHE will also identify system leaders across the country to lead local sexual health, reproductive health and HIV commissioning within an agreed locality and to form a national network of commissioning leads to promote effective national development of commissioning. To test out how this might work in practice, PHE will pilot local delivery models working with local authorities and CCGs to help build on effective models of commissioning. We will announce the names of the pilot sites shortly, as this work is still in the early stages of implementation. However, I would like to take this opportunity to urge any areas that are interested in working with us to get in touch with PHE and to take part in developing this work as it takes shape. I shall.
Warmly welcome what she's just announced. But if, when these pilots have been up and running and have delivered results, it is necessary to revisit some of the structural changes and commissioning changes that were made under the Health and Social Care Act that caused the problem in the first place, would she be open to revisiting those? And also on the question of the ring fence, if she's going to delay it a year, she might as well have a proper review about the impact of removing the ring fence, given the concerns that we already know are out there about the impact of removing the ring fence on public health funding and spending in general.
I think he slightly misunderstood me with the ring fence. The reason we've kept the ring fence in place is because we believe we need to put in place some transparency and accountability measures so that when local authorities do move to business rates retention, their decisions can be made in an appropriately accountable way, which can be scrutinised properly. And we don't feel like we have that yet, and so we have moved the date back a little bit. And we want to do that in an effective way, and also we want to take in place a proper consultation for the mandate. On the second point, I think it's a little bit early in the process to start discussing that. But I'd also just like to move on, given time, to service specifications, because during this debate we've also heard examples of where contracts for sexual health services have become divorced from the provision of HIV services. And one of the key recommendations of the APPG report was to create a joint service specification for sexual health and HIV services. Now, we recognise that the existing service specification for sexual health needs strengthening, and that is why it is now being updated. PHE has committed to building on existing commissioning guidance to provide a more focused advice and examples of locally designed systems to support the commissioning of HIV and sexual health services. Now, NHS England is responsible for the service specification for HIV treatment and care, and we consider that this remains a sensible division, but the development of a new integrated service specification for sexual health services will allow us the opportunity to join up our advice to produce a more integrated offer. And finally, as many colleagues mentioned, I would just like to take a moment to recognise the continuing priority of PrEP and the trial which PHE and NHS England announced last year. Up to 10 million has been set aside to fund the trial. It is anticipated that it will include at least 10,000 participants over the next 3 years. We expect the trial to be underway this summer, and it does have the potential to change the lives of thousands of people at risk of contracting HIV.
Quickly, Mr. Wee, I know I asked the question in my contribution, as did the Honourable Member for Exeter as well. We referred to the older generation and where they featured. You haven't perhaps just touched upon that yet on the figures game. Maybe if you can, if you're not able to now, you can come back to this by letter form. Thank you.
Minister. The whole point of developing a much more systematic process of having a commissioning programme which does not allow fragmentation of the services but instead has a much more integrated system, we believe will take into account more ageing HIV, people living with HIV, and we believe will deal with that. But you also raised sort of how we will address the issue of tackling those living with HIV undiagnosed in the community. And so the strategy is simply increasing education and bringing in compulsory SRE, we believe will be part of that. Improving our performance and testing and early diagnosis and the work through the Innovation Fund, we believe, is a key plank of that. And also having clear specifications and commissioning guidelines so that we have coherent services for all who need to seek it is the strategy. And so we think that that is a coherent response. And I think that we can be proud of the moment. I shall.
If you could write to members to give some clarification of what will happen to those who are currently on the PROUD trial while there is a gap between the drug stopping and the new trial starting. If you could write to members, that would be appreciated.
Minister. That's a very important clarification. I should be very happy to do so. I do think, in closing, that we should not underestimate the progress that we have made in testing and diagnosing HIV, down to the campaigning and the very hard work of many people in this room and many of the campaign groups out in the community who also provide services and are the bedrock of the service that we have out in this country, providing world-class services for people who do live in the UK with HIV. But what today's debate does show is that our way forward is not free of challenges, and we must continue to reflect on how best we must deal with these and to meet those challenges. I hope that the commitments that I have announced today go some way to reassuring members that the government takes these issues very seriously, but the government cannot do this alone, and I am sure that we can continue to rely on the wisdom and the support of all of those in this room, the incredible work of voluntary organisations, so that we can finally achieve our goal, the one which we have all been working towards for so many years, which is a world that is free from HIV/AIDS. Thank you.
Thank you, Mr. May. Can I thank members and right honourable members for their time this afternoon, which has been, I think, a constructive debate, but also to thank the Minister specifically for those commitments on extending the ring fence, for recognising that work needs to be done on the commissioning model, and for the work that the PHE will be doing on a new action plan to support the pilots to address those issues on fragmentation and that all-service specification. Those are all very welcome announcements. Mrs Main, we've come a long way from HIV/AIDS being a death sentence to it now being a manageable condition. Yes, that's largely to do with drug breakthroughs, but importantly, it has been delivered through a coordinated response both from public health and the NHS. And I do hope, Mrs Main, that this debate will help avoid undoing the progress that we've made.
The question is that this House has considered an APPG report, Impact of Health and Social Care Act on HIV treatment. As many as have been say aye. The contrary, no. The ayes have it. The ayes have it. Order, order.